It's okay with everyone, we'll get started. On behalf of the APSA Transition to Practice Task Force, we'll be speaking today about successful transition to practice. None of the speakers today have any disclosures. This list represents the Transition to Practice Task Force members, led by Dr. Mack at the end of the table, and the group leads are listed as well. This group was created to try to bring geographic diversity, practice diversity, length of practice diversity into this discussion. We presented last year at APSA, and at that presentation we discussed the task force creation, the survey that we had sent to the membership, and those survey results. We will not be reviewing those today, but they are available on the APSA YouTube website on PEDSurge TV, and this QR code will link to it, and we have the QR code up on the last slide as well if you miss it. Today's talk is going to be centered over a few subjects, and with the first subject I'm going to pass to Dr. Pulagandla to discuss training program responsibilities.
Thank you, Butter. So for the vast majority of fellows, the pursuit of and confirmation of job opportunities is a significant source of stress, and it just adds to the rigors of pediatric surgical training. The faculty-fellow relationship is something that can be leveraged in order to try and reduce this stress. For sure, the faculty mentor has the ability and the relationship in order to explore the drivers behind job selection for the fellow, which are often quite personal. This allows also an opportunity for faculty mentors to be able to look into the decision-making process and also highlight red flags if they occur, and also provide a perspective that perhaps the fellow may not be initially appreciative of. Moreover, what is really important is that the selection of a job is often so stressful that everyone is very focused on making the correct decision, but only time allows us to determine that. So it's actually the job of the faculty mentor to make sure that the process is correct, and that time will tell us what happens with respect to the actual source. Also, the use of an onboarding checklist, which will be presented by Dr. Jones, is also a nice effort, another opportunity to screen the process. Thanks. So training programs do have the responsibility to provide independent practicing environment for their fellows. This can often happen as a pretending or a junior faculty role where they are able to make decisions but also have the adequate supervision that is required for them. This can happen in the context of a fellow-run clinic where they are looking at evaluating patients and booking ORs. It can also happen with respect to running a day list where they are not only interacting with the interdisciplinary OR team, but also engaging with junior learners and understanding and managing the operative OR, flow and OR time management. Other opportunities for fellows to take on leadership roles include involvement in driving discussions with respect to multidisciplinary teams, and also leading discussions with families. I also believe that there are many opportunities where this idea can be socialized on many different levels, from the beginning of fellowship all the way to the end. This can start at the APS TPD Transition to Fellowship course or the boot camp. It also can happen at the AP Fellows Conference, which I know also already contains aspects of job negotiation, and also at venues such as this where we are getting together, and break shops at the annual meeting will also be an opportunity to discuss these issues. I'd now like to give the podium to Dr. Jones to discuss the onboarding checklist.
Thank you. We created the checklist to serve as a two-way communication tool to facilitate the onboarding process for junior pediatric surgeons. It's meant to cover a wide range of topics and can be modified to fit the needs of individual institutions. We envision that the checklist will serve as a conversation starter to help new surgeons know what questions to ask in their first jobs, and to help division leaders review their institutional practices and culture to help facilitate a smooth onboarding process. Ideally, most of the information contained within the checklist will have been discussed during the interview and hiring process, and a copy of the checklist will be available in a QR code at the end of these slides. We begin the checklist with information about the operating rooms. This should include introductions to the staff in the OR, as well as tours of the physical space and review of the equipment that's available. It'll be important for new surgeons to learn the method of scheduling both urgent, elective, and emergent cases. For instance, is there a separate method in place for booking a case with the assistance of a senior partner? Guidance from senior partners regarding realistic case durations and time management optimization will be critical for the new partner's success. We advocate for a period of case proctoring for all surgeons joining a new practice. This time of proctoring will not only help the new surgeons with challenging cases, but it will also help to introduce the surgeons to the operating room culture at a new institution. The type and duration of intraoperative proctoring will be unique to each institution. As new surgeons gain experience and familiarity, it will be important to know the system through which they can obtain help in the future, as well as to have a shared understanding of the types of cases that should have assistance from partners well into the surgeon's time in practice. Thorough preoperative case preparation is a hallmark of safe surgical practice. Ensuring that new surgeons have access to preoperative planning conferences as well as didactics will help prepare them for the operating room. Even if no formal pre-op conferences are in place, establishing a culture of open communication amongst the group can facilitate planning discussions to help junior partners be ready for safety and success in the operating room. We recommend a formal review of care in the outpatient setting. New surgeons should be instructed on the methods for scheduling outpatient visits. If clinic-based procedures are a part of the local practice, the types of procedures should be reviewed. A tour of local referring providers' offices is beneficial. We believe mentoring should be available for outpatient care. Advice from experienced surgeons about how to best engage community physicians in the expansions of a new surgeon's clinical practice can be beneficial. Ultimately, who is available to call when a new surgeon is looking at something in clinic that they don't recognize? We recommend formal tours of inpatient facilities and introductions to the inpatient care team. Introductions to leaders of other service lines, including the NICU, the PICU, emergency medicine, and pediatric hospital services are very important. Establishing a rapport with nursing administration leadership can help down the line when the inevitable questions of who can help me find this answer come up. The administrative portion of our checklist includes many of the day-to-day activities of a surgeon in practice. Who is responsible for coding and billing, and what resources are available to help a new surgeon with this part of the job? Are there off-site hospitals covered by the group, and if so, how does that coverage model work? What is the process for transferring a patient into and out of your institution? It will be important for the new surgeon to understand the benefits that are included in their new position. Are there funds for academic pursuits available? When adverse patient events occur, it will be important for the new surgeon to understand the process for event reporting and then to know what services are available to provide them support through their experience of a patient who has an adverse event. For those jobs with an academic component, expectations for academic performance and promotion should be established during the onboarding process. This should include a review of the resources available to facilitate academic success. There should be a clear pathway for promotion. It will also be important to review the expectations regarding new faculty interactions with trainees. While each job will have official policies on many issues in pediatric surgery, there are also many unwritten rules in the workplace. The earlier in the orientation process that everyone in the group can agree to a consensus about ideas of work-life balance, unique aspects of the group's culture, and methods of conflict resolution, the better it will be for the team as a whole. Initial meetings with leaders in the hospital and group administration will help establish culture and expectations, as well as forge relationships in a new job. Perhaps just as important will be following up on those meetings at a planned interval. We don't prescribe a defined timeline for that interval, but we do recommend that one is established early. And now Dr. Berman will discuss establishing a supportive culture.
Thank you so much. So I know we're not focusing on our survey results, but I just wanted to highlight a couple really pertinent findings that are relevant to this section about culture. So when we asked new grads whether they felt supported, whether they felt comfortable asking for help during their transition from fellowship to practice, the vast majority of them said yes. They felt very supported. They felt comfortable asking for help. But that was in spite of the fact that very few reported that there was any formal mentorship or formal training. So I think like the big message here is, even without formal processes in place, most of us feel very supported. And I think that really comes down to having a supportive culture. I think having formal processes in place can help create and sustain a supportive culture. So I think the processes are very important, but I'm a strong believer that it all comes back to culture. I put a bunch of the percentages on the slide that I'm not going to go through. You can look at them. And then similarly, when we asked about surgeons' experience with adverse events, now this wasn't just new grads. We asked this to all the surgeons who took the survey. Really, the summary of those findings is that adverse events are ubiquitous. They are going to happen to all of us, sometimes because we make a mistake, sometimes just because our patients are very sick. When we are in a moment where we feel like we are struggling in a clinical situation, most of us do feel comfortable asking for help, and even asking after something happens for emotional support from our partners. There was less trust expressed in the hospital as a source of support. But then again, we found there was a critical minority who don't feel comfortable asking for help or support. And I think it's the critical minority that doesn't feel support in mentoring or in recovery after adverse events that we really want to think about, how do we reach that critical minority? So we're going to talk about culture. So this is really from the perspective of the partners of the group. When you have a new fellow grad that is coming and joining your practice, what can you do to create a supportive culture, particularly the senior partners? But I think sometimes the most supportive people can be actually the ones who are fresh out of fellowship because they've just lived through that transition themselves. So I like how this is phrased, err on the side of being too available and almost intrusive. Don't wait for them to ask for help. Just be right there to offer it. We all encounter situations where there's a disagreement, like we just heard about in the clinical case conference, the PICU's insisting on you doing a lobectomy for your bronchopleural fistula. So in that situation, you always want to have your partner's back. Even if there's disagreement within the division, when you are interacting with other services, it's important to present a united front. It is good to provide feedback if you don't agree with the decision that was made, but that should be sort of in a closed door format. And when you're interacting with other services, you want to be united and always support your new partner and stand up for them. OR. So if you know that your new partner is doing, their first big neonatal case or tumor or whatever it may be, you might sometimes have to prioritize, missing a meeting, running out of your clinic to check on them, to be available to help them, and not necessarily even wait for them to ask, just kind of pop in and check in on them. One of the things I love about our group is if I'm doing a big case, even now, 10 years out, I know my partners are going to just be popping in to see how things are going. So it kind of goes up and down the hierarchy. So on call, it was interesting because we asked in the survey, do you have a backup call system? How often do you actually get called in? And I think sometimes we don't have formal backup. Sometimes even if they exist, you almost never call your backup because it might be seen as a sign of weakness. But I think when you are serving in that backup call role, you really want to be present, especially as your partners are transitioning from fellowship. Many of us work with trainees, so I think it's really important to set clear expectations around, what levels of supervision are needed for the trainees. We've all faced certain pitfalls. We want to be very open in sharing, our successes and failures in dealing with those pitfalls that we have faced ourselves. Many of us have families or have, obligations outside of work. And I think just being very available to help cover duties as your new partner is settling into their new home, getting their kids started in school, et cetera. We just want to be available to help and not overload their clinical schedule during that transition phase. And then I think, again, it comes down to culture. I think we can set an example as senior partners by asking for opinions and asking for help. And that kind of creates a tone that, she's asking for help. She's been doing this for 10 years. I feel comfortable asking for help as well. And that it's just an expected thing that we do. And now we have the picture portion of the session. Dr. Edwards is going to continue from there for the division chief perspective.
So I was asked to just comment on sort of the role of the division chief or the hospital leadership in kind of these cultural issues. So those of you in the room that are division chiefs or surgeon-in-chiefs, you trained probably when I did or earlier, and you may have felt like this at the first day of your first job. I know I did. And you just kind of were thrown in the middle of it. And this wasn't malicious. This is just the way it was. It was thought that you have to make your own decisions, figure things out for yourself. And, you know, that was kind of critical to your development as a clinician. And it was just expected. And the role of the division chief was this. So when you set up the distress signal, they would throw you the lifeline, pull you off, or pull you out just long enough for you to get back in. The problem with that is that that leads to near drowning experiences, and people don't always recover well from those. So time goes by. Contact hours during training went down, surgery became more specialized, outcomes became highly scrutinized, and the role of the division chiefs started to look like this. They were like the protective gear, sort of the thing that was going to pad, the new partner from getting hurt or hurting the patients, protecting the hospital, protecting the division, protecting the reputation. The problem with that is then, your new partner can start to feel like this. And you have to walk a balance because these partners are now your colleagues. They're not your trainees anymore. And on some level, they do need to have the ability to feel free to make their own decisions and give you their honest opinions. And you should listen to that. It's a different perspective, particularly if it's someone coming in from another institution. Cross-pollination of ideas is great. So what you really want to do, I would submit, is you want to pave the way. You want to pave the way for your new partners, everyone in your division, to sort of get through this journey of their career. And sometimes that does mean putting guardrails around them. But for the most part, it means filling in potholes, throwing up road signs, just to make things more comfortable and easy for them to navigate. Because this is what we want. We want success for people in our division, our partners, our colleagues, because success for them is success for the division. So how do you pave the way? So it's kind of already been said. It does come down to the collaborative and supportive culture in the group, but how do you get there? So, culture is difficult to change, but I would submit that as a division chief, it needs to start with policy, because you are, to a limited degree, in charge of policy within your division. And you have to understand that people that join your division may not be equally receptive to the idea of calling for help, getting proctored during cases, double scrubbing. Some may welcome it. Some may see it as overreach on the part of the division chief or the senior partners. But if you make it the same for everybody, it's the same for everybody. And then when you get in there in the operating room, if you are supportive and you are collegial and you're not overbearing and you're not treating them like a trainee, they're going to want you there anytime they need you. And so I would say that policy can support culture change in this way. You do need to have firm guidelines, I think, regarding what's done at outside hospitals. That should depend on the degree of support that you have at these outlying clinics and hospitals. And it shouldn't really change from provider to provider or surgeon to surgeon. You do want to treat people fairly. And I can't overstate the need to praise in public and criticize in private. And that goes both ways. A division chief's sort of like a middle management position. And so you're the interface between the division and the institution. You don't want to badmouth the institution in front of people within the division. but you do want to send concerns up appropriately. Similarly, your division is a united front in front of the hospital. And so if there's a problem with the provider, it's a problem, at least in my mind, within my division. The division is a family, they're a united front. If there's problems internally, then you manage that internally. Forward-facing, you're united. The final thing I would mention is sometimes we get hires that we didn't want. And it happens. But once they're in, they're in. They need all of your support. And whatever feelings you had before them coming in, you don't want to treat them any different than you do everyone else in the division, because that's just going to erode morale within the group. And that's all I have. So our fearless leader. Oh, no one wants to feel this way. That was my final slide.
All right, so in conclusion, like we have already discussed, last year's presentation was really where we concentrated on the survey and the results. And it was based upon all of those results from the survey of the entirety of the APSA membership, where we were able to develop these best practices that we are presenting to help ensure a successful transition of practice. Again, just to reiterate, this starts in fellowship training and it continues through their job search and then into their first few years of practice. It involves everyone in the practice, from the chief to the mid-career to the senior partners to the brand new, newly hired surgeon. And we hope that these tools will help to anticipate future needs and prescribe dedicated conversations that can really help support appropriate personal and professional development for the new hires into your group. And this is just a sort of a quick outline again of everything that is part of our best practices in fellowship, having sort of junior attending or pre-attending training, counseling and mentorship during the job search. In terms of our checklist, we have an onboarding set of guidelines that we recommend. So that includes the operating room logistics, surgical case backup or proctoring assistance and discussions, outpatient clinics, inpatient clinical care, and as well as just overall proctoring. We also divided out administrative, mentoring, research, and academics as part of our onboarding process, conflict resolution and communication techniques, and then creating the culture of a supportive environment and system. The goal of our group is now to take all of this information and to synthesize this into a manuscript, and then we're also going to create a best practice toolkit available to the APSA membership. These are the two QR codes that we talked about. The first on the left is the presentation from last year, and then on the right is the onboarding checklist. We'd welcome any questions from the group.
Thank you. I'm Gabriella from UCSF. It seems like you, as a senior leadership, are taking on a lot of that burden, spending the extra time, being the backup person, checking in on the OR. Is there also a role then for the junior person to be more proactive and go to that senior person's case, maybe shadow a clinic, figure out what some of the efficiencies are, just to kind of keep that burden, equally shared between the two sides?
Yeah, so we didn't present sort of everything that we came up with, but we did have a section on regarding responsibilities of the new hire, and one of those responsibilities is being very transparent regarding what you need from the institution, what you think your limitations are, and that conversation should be had during the hiring process. But absolutely, I mean, you need to take responsibility for your own career, no question.
And I think the checklist too, that's why you provide it to the junior person so that they can see both sides.
Vanderbilt University. Thank you so much. It's a great presentation, a lot of information, and I think it'd be great to have the manuscript so that we could have a checklist to know that we're all doing our tasks. Question about for those of you who have been the person coming in, as well as for the leaders that are onboarding people. I think one of the challenges is when you initially have people who are developing a relationship with each other, there is not necessarily a psychological safety. So you would say, how are you doing? Doing great. Having any problems? No, just fine. And how do you go from there to where they could say, you know what, I'm struggling with that outside hospital I have to cover at. I'm having challenges with that interface with the OR nurse. You know, where there's that vulnerability, how do you create that language to be able to start that conversation?
Well, you need to check in. I mean, you need to check in frequently, I would submit. And when the new hire joins, depending on how big your practice is, you need to schedule regular meetings with them. I don't think it's really enough to just say, I have an open door policy, which you should have an open door policy, but there should be scheduled meetings regarding you're going to come in, you're going to talk to me, and even if we just look at each other for 20 minutes, you know, I mean, because if you don't force that, if you don't make it happen, like you said, different people are going to react differently to it. Some people will see it as a sign of weakness. Some people will embrace it. And some people will want to do it but be afraid to because it's a sign of weakness, and some people really don't want to talk. But I would submit you have to force it. It should be a scheduled thing.
I know for me in my first job, I felt like I was drinking from the fire hose for months. And, you know, my senior partners regularly approached me and said, hey, how's it going? And then, you know, would fill in, I remember when I was new and XYZ happened. And it was reassuring to know that, you know, the struggle is real and it's shared. And so I think as a junior person, to know that, like, it wasn't always easy for everybody, that really helped me to kind of open up and say, okay, yeah, I'm nervous about this lump on an arm I saw in clinic, and I'm embarrassed to say that out loud. But then they said, oh yeah, those are scary. And so those sorts of things of, you know, like, I think showing some vulnerability from the senior partners can kind of help open up that discussion.
I think there's also the need to keep your ear to the ground. I think there are many opportunities to be able to tap into other team members, nurse practitioners, other members of the OR team, perhaps anesthesia or scrub nurses, and just to sort of say, hey, how are things going? And you may get some stuff that you'll just say, okay, that's just fine, that's just normal stuff. But then you sometimes hear things that that make you a little bit alarmed, and sometimes the easy things like behind on OR dictations, not finishing clinic notes. I mean, that sometimes can just be, okay, I just had a bad clinic, and we all have those. However, if it's repetitive, then that might be a symptom of, okay, all right, let's take a step back and let's just have a coffee and chat about stuff. And, you know, how are things? Are things a little bit too busy? If, you know, you have a lot of challenging cases on your list, you know, how is that going? So I think, you know, just being able to leverage your ears and relationships as the division chief with, you know, who you have can really be very valuable in trying to sort of, you know, identify those very early on.
And I think that's also why it's really important to establish the culture early on, because if you have that culture so that it's everyone in the group that is open and talking about these things, and I think that also helps to encourage that.
Smiling. So you guys have done a great job, right? You were the transition to practice task force. And one of the things that we've defined in APSA is the difference between a committee and a task force. A task force has a designed role and a time frame. You're going to write a manuscript. You've got a toolkit. Do you guys think you're done? Or what is the next stage of what you're doing? Have you thought about prospectively studying a cohort of graduating trainees and available jobs and their program directors to see if all the hard work that you've done is really making a difference?
That is an excellent idea. We actually hadn't talked necessarily about studying proactively and prospectively, which I think is a really good idea. What we had also talked about is transitions of practice for other parts of your career. So like in the mid-level, transitioning to like leadership roles, and then for more senior people transitioning to being more of a mentor and maybe a little bit less clinical and that sort of thing. So kind of throughout your career, having different areas of transition, but definitely having proactive data collection would be really good to be able to prove that this actually helped, especially because we already have our baseline survey. Thank you.
To the first question's point, and then to the earlier discussion, one of the ideas that spurned the OR, the onboarding checklist, was to say, let's normalize this as a part of the conversation. So I was certainly the more junior side of this task force, and to say it can be intimidating to sit and ask all of these questions. And so if there is a checklist, you could not only use it to evaluate a job and say, these are the normal things that are always discussed, but on your quarterly meeting or monthly meeting or biannual meeting, whatever it may be for professional development, to allow that. And that is perhaps a metric that we can track and see how often that is being utilized and if that's really picking up in practice, to allow that. There were some other questions that have been raised in the process. So one question I had for Dr. Pulaganla was, people have discussed that when fellows or junior attendings are assessing a new job, that they may be looking at certain factors that are personal and balancing those differently. But what have you seen in your experience that fellows undervalue, and what have you seen that fellows overvalue when they're looking at a first job?
Thanks for the question. I think there's always this, it's sort of like the Holy Grail, right? You're looking for the perfect job. A lot of it's related to the scope of practice that you're actually able to participate in. We all went into pediatric surgery for its breadth and its scope, and we love working with families, and we love the physiology, but sometimes you have to temper that with what reality actually offers you. For many, it might be a family motivation to go back home because that's the support network, and that's a huge driver. For others, I know that there are some new graduates who actually will actively pursue locum tenens positions. Now, however your personal feelings are related to that, I think it warrants a discussion. And there are many drivers. There are financial drivers. There are other things that perhaps no one knows about that are driving that decision. But I think from a faculty point of view, having that discussion perhaps will open the door a little bit to give you a little bit of insight as to what's driving it forward. And I think it's also important that it doesn't have to be a program director, but I really believe that mentee mentorship, it's very organic, and that just develops over time. And it may not even necessarily be someone within your program. It may be someone outside of it. And I think that's where I think we would be able to hopefully exploit those opportunities.
Ron Herschel, Ann Arbor. So I was wondering if you had talked about launch teams and thought about those. Is that familiar to everybody, or is that a new? Okay, so all right. So I will tell you that at the University of Michigan, when a new faculty member comes on board, we give them a launch team. And one of the reasons I call it that is because different faculty members have different roles. Some are going to be doing health services research. Some are going to be doing our clinical. Some are going to be doing laboratory. Some are going to be doing education work. Some are, there's all these different areas where they're going to emphasize. Everybody's going to end up being a pediatric surgeon, but they may be predominantly clinical. And so we have a launch team. And that launch team consists of individuals that their senior, leader and often the individual discuss who's on the launch team. So, launch team could be their research mentor. It could be some of, let's say they were coming in and we're going to be doing colorectal. It might be somebody from GI, and it might be somebody, from the sort of DSD angle or whatever it is. We surround them with individuals, and then we usually throw in some people that just are really good at kind of, well, you pave the way kind of people, people that understand how to function in the environment. And the launch team usually is about 6 or 7 individuals, and it's amazing how people are willing to pay back with their time and give them the advice and hold them to task. That's the other thing. So, in other words, if you're planning on, I want to set up a DSD program, I'm going to take that, okay? And where are you on setting up the DSD program? And what are your hurdles? And how can we break through those hurdles and help you and so on? Anyway, I just wondered, one of the things that helps is, especially because we have so many individuals that have different, emphasis. And so we found it to be very helpful to young, new faculty members.
Thanks, Dr. Herschel. That was great. We actually did see that on the survey, but all it said was launch team, so we didn't know what that meant.
It was also very interesting on the survey just because of obviously the diversity of practices within pediatric surgery, to hear people's responses, especially the write-in comments. Some people would write in, of course we have a backup system. How could you expect someone who's new to pediatric surgery to be dealing with the breadth of pediatric surgery the second they step up? And then, the comment that followed would be, I already take enough call. I can't be a backup. I'm in a group of 3 or a group of 2. And so at the end of the day, a lot of the recommendations were made to try to cover the breadth of different types of practices. A launch team would be amazing, but obviously very resource intensive.
No, I agree with what's been said. I mean, that sounds like a really useful tool, and it's helpful to understand the details of how it works. I think in the survey, a lot of the time people are just inclined to complain about what doesn't work. And we did ask some very specific questions, like, are you in a place where you had a good experience, and how did that get accomplished? So to the extent we're able to gather specific examples just like that one and provide enough detail in our toolkit so that you could replicate that in your institution, I think that'll be really helpful. So.
All right, so I'm going to ask this question to Dr. Berman because I think it dovetails with some of the other work that's done. So how does one proactively support a colleague that may be having issues similar to the ones that were mentioned on your slide from the comments? And what APSA and other organizational resources have you found most beneficial? When does that line move from personal support to needing more support?
So, I think in an ideal world, within every practice, there would be a culture where you would never need a safety net program like what APSA has through a peer support program, or even institutional peer support program. I think we should all work in divisions where, when something bad happens, a death in the trauma bay, a traumatic ECMO cannulation, an intra-op mishap, we are just going to be checking in on each other, and that's just normal. And then it's also just normal to talk about how we're feeling about it. I think we're very far from that. So I think we really need institutional programs, and APSA really is the ultimate safety net. So what you're referring to is the APSA peer support program. I think there's a lot of other really great tools out there. Kathy Van Leeuwen has been running sessions about critical incident debriefs and teaching surgeons the skills, that moment in the trauma bay after the patient dies. How do you kind of gather the team to have an immediate debrief? So I think the more we learn, APSA can provide education about how do you provide peer support, how do you run a critical debrief, and then we can bring these back to our institutions so it just becomes part of the culture and normalizes the fact that what we do is really, really hard. It's incredibly rewarding, and I feel so lucky to get to do this job, but there's a flip side to that. I see APSA as really a platform to provide training and resources so that we can all be kind of self-sufficient. But until we get to that point, you know, we can actually provide the support through our program too.
So it's about it's not about, it's 5 o'clock. We don't want to make anyone late for the next session. So thank you so much. Please let us know if you have any other thoughts, comments, suggestions. Thank you.